Hello, and welcome to another episode of the Melbourne Athlete Development Podcast. Today, I'm very fortunate to be joined by Natalie Brettler. Natalie, thank you very much for being with us today.
Hi, Jack. Thank you so much for inviting me. It's such a pleasure.
Now, I'm really excited to have this conversation. Now, to give some context to the conversation, can you introduce who you are and specifically talk about your background and what you do within your professional work?
Sure. So, I'm a physical therapist from Israel. I'm a fascial manipulation teacher, and I'm the head physical therapist of the Israeli national rhythmic gymnastics team. And of course, I have my own private clinic in Israel with 8 more workers.
Yeah.
Yeah.
The great thing, I was very fortunate to meet you with the Fascial Manipulation International School program I'm doing. And I was very fascinated to hear some of the work that you've presented on because you've also presented through the Fascial Manipulation Institute, talking a lot about your work within the gymnastics team, and then talking about how you actually implement fascial manipulation, not just from a management of pain, but also from an injury prevention standpoint. So, I mean, it'd be actually maybe even take a step back just to talk a little bit about how you got into gymnastics, because I think that also um, is useful to think about your background and how that influences your interest in gymnastics and how that probably influences what you do as a physical therapist, and then we'll go on from there.
Sure. So, actually, I was a gymnast. I was a very, very sick child. And my parents, when we got to Israel, my parents told themselves, okay, we have to do something with her. She is so sick. I was constantly at hospitals, and they told, okay, so we need to send her to sports. So actually, I was a rhythmic gymnast. I started just for strengthening myself, but I got to the Israeli team. I was part of the Israeli team, and unfortunately, when I was 15 in 1999, it was a long time ago, I got injured 3 weeks in an international competition just before European Championships. I teared my ATFL and I couldn't compete in the European Championships. But no one could rehabilitate me. I think it took me something like really maybe nearly 4 months or even half year
Mm.
to go back to sports. Of course, I didn't participate in European Championships. I was so disappointed. I was devastated. I felt like my body betrayed me, and I felt I betrayed all my environment, my parents, my coach, everybody. And this was actually my first meeting with the physical therapist world, with the physical therapy world, and I was very disappointed.
Mm.
Um, because first of all, they couldn't rehabilitate me, but mainly also we didn't do a lot. We did electricity.
Oh, I've just lost you there, Natalie. I know you're back. Keep going.
Yeah, I'm with you. Sorry. Um, so
That's
we
okay.
so we did cold therapy, electricity, a lot of exercise, a lot of exercise, and mainly that was it. So my first meeting with the physical therapy world wasn't exciting at all. But then
Well,
yeah,
no, keep going.
but then I studied physical therapy, and I have to say that I was constantly in a search of, okay, so what else? Where is the
Mm.
three-dimensional look on our body? So we learn about the thigh and the knee and the hip and the chest, and the neck, of course, but how is everything connected together? And how do we actually see the body in a 3 dimension? So I learned physical therapy, like bachelor's degree, BPT, and I started to study a lot of different methods. I remember even going to Reiki because I thought, okay,
Mm.
maybe this will bring me something like a holistic look, right, on the body. But during
And just out of interest, as you were going through this process of learning about different methods, Was this something that you were seeing a lot of your colleagues, a lot of your other physical therapists doing, or were you the odd person out who was really trying to branch out and learn something
I
different?
was I was totally odd. I was
I can certainly relate to that.
really, everybody was learning and said, wow, how much knowledge, it's amazing. And I was, okay, wow, how much knowledge, it is such a complex world, but how does it all connect
Mm,
together? And this is what I
mm,
didn't really find. So I learned Reiki and I said, okay, but what about the anatomy and the physiology I was learning? I kept on learning so many methods when I finished physical therapy school, but I have to say that something was constantly missing. And then one day I read about fascia. I read about this article from Stekos, and I
mm,
said, oh, wow, this is something that is interesting because it connects the musculoskeletal system and the visceral system and the cells, even the cells. And it somehow showed a very, very important and very organized connection between the different parts of the body. So I said, okay, interesting. I went to the course of fascial manipulation, level 1. And you know what? The first thing that I was asking, I had a patient with Bell's palsy,
mm,
with fascialis. And I remember I couldn't help her for 3 months. And you know that in Bell's palsy, you have like zoom in as time passes. It is very difficult to help them. And I went to the course and I asked my teacher, tell me, so can fascial manipulation help for Bell's palsy? And he said, yes, but you have to start from the source of the problem. And I said, well, yeah, it's the facial nerve. No, no, no. Start from the history of the patient. So I went to the patient, and by the way, I have the picture. Um,
mm,
and I asked her, okay, so what is your history? And we spoke about the Colles fracture 6 years before the Bell's palsy. So I took
mm,
all my books, put it on her. I was just right after the first course. You don't remember the points. It's super hard. I've put my books on her and I said, okay, we're starting something new. And I remember that I've been touching antecarpi, which is it's a point in the hand. And she told me, listen, I feel my face. And I said, no, no, no.
mm,
You cannot feel the face because there is not a straight connection. So I'm sorry, but you can't. Anyway, a week after, she had full symmetry,
mm,
and that was amazing. This is how I felt in love with fascial manipulation. And this is where I actually understood, okay, there is something interesting here that gives me all the connection and all the three-dimensional.
mm. Well, I'm interested for you to explain that because I think that's a great example. And I don't know if it's similar for you, but I know for me, when I talk about something like fascial manipulation and say talk about a connection from, say, the forearm to, in this case, the face, a lot of people look at you going, "What are you talking about?" I mean, like you said, Bell's palsy. It's just a facial nerve uh, uh,
Yeah.
pathology. How would such a thing be related? And so, here we have Natalie, a fascial manipulation teacher. You've been doing this for a long time. I'd be interested for you to actually just elaborate a little bit more about talking about, the anatomical relationship and how that connection can potentially be, because I think that's a very valuable insight for our listeners to be able to expand their understanding.
Yeah, so actually, wow, fascia is such a huge, wide topic, but
Mm,
let's say it very, very let's simplify. The connective tissue is what actually connects all the structures in our body. Sometimes when we're saying that, you think that it's just a connection, but there is a very strict and organized connection between the different muscles, between the different internal organs, between the different structures in our body. And when we understand this connection, we actually understand that also a fracture in the wrist, in the forearm, can actually make some kind of pathology in the face and in different structures. So a pathology, a fracture in the bone can make later a pathology in the nerve or even in internal organ. And This is when you understand how complex is our body, but also how organized it is. It really helps you to understand different symptoms that you will never connect between them. By the way, let's speak just a small thing about our internal organs. Okay, usually when you come to a doctor and you told him, listen, I have a problem in my digestive system, right? So usually he will treat your problem in the digestive system. But as a fascial manipulator, you will ask, but what about your respiratory system? Do you have any problems with some kind of breathing problems? And this is a connection that by the anatomical connections, by understanding better how our body works, we can actually understand the connection of different symptoms. So this is amazing.
Yeah, and I think the big thing too, and this is something that I've spoken about with other guests on the podcast, is that the biggest issue I see at the moment is so much of the anatomical specimens we see when we open up a textbook, if we see a cadaver, most of the time the fascia is removed. And so I think this is often one of the big issues to begin with because our conceptual idea of anatomy doesn't take into consideration the fascia. And there's two things to consider here: the obviously the deep muscular fascia, which you can see the continuity and helps to perhaps explain that relationship between that old fracture to the face. And part of that is also, I think people need to understand that when you say, for instance, have a broken bone, yes, the bone has healed. Yes, you can obviously start to get movement back and start to use exercise rehabilitation. But quite often, that something that's missed is the changes that occur within the fascia itself. And it's that change that happens from that immobilization, the lack of movement, the actual injury and inflammation, where it's the way that the body keeps the score, so to speak. And those issues of those changes in the fascia, where you get as tensifications, which I've talked about before, they accumulate in a particular pattern, as you mentioned, because the fascial system is very organized, and then start to manifest elsewhere. And it's a very clear connection. You understand. It helps you to really appreciate that most of the time when someone presents with a problem, particularly if it's an insidious or a gradual onset, there's always an underlying reason.
Yes.
And then, of course, we can take into consideration, as you mentioned before, too, the internal or visceral fascia, because there is also a very clear relationship between different apparatus, you may say, or different subsystems of the body that help us to understand the subsequent symptoms that follow that may originate from an issue elsewhere in the body.
Yeah. By
Now,
the way,
go
let's
on.
go to this connection and connect it to my history of how I became a
Mm,
physical therapist. So when I was a physical therapist student, I got a neck pain every 3 to 4 weeks. Every 3 to 4 weeks, I was stuck with my neck. Nobody could help me. I went to the best physical therapist because actually I also wanted to learn about the different methods.
mm,
And
mm,
every time someone touched me, it became worse. And every time like that, I
mm,
got stuck every 3 weeks. After 5 days, it got better. 3 weeks, stuck again. When I got to the fascial manipulation course, remember I told you that I was injured just before my European
mm,
championships, right? When I was a gymnast. So when I came to the fascial manipulation course, I was as a model. And I came again with a
mm,
stuck neck. And the teacher asked me,
mm,
so tell me, what is your history? What did you have in your history? And I told him, well, actually, I just had 2 traumas in my leg. One when I was 8, and the one with when I was 14, it was on the same leg when I sprained my ligament. I ruptured my
mm,
ligament. And well, this is it. So he said, okay, so we are going to start from your right leg. I'm like, what? My right leg? But I have a pain in my neck. And he said, and
mm,
he explained exactly what you told now, the continuity between the different parts of our body. So when he started from my foot, after he treated me, that was the first time I didn't get the neck pain again. And that was
mm,
my thing. And then I remembered that I told to myself, oh my God, actually, what I was doing as a student, I started to run. I wanted to run to maintain, my physical fitness. I started to run. I got the neck pain. And then I stopped running because I couldn't because of my neck pain. After 3 weeks, I started to run again. And I got again my neck pain. And that was the chain that I did for 4 years. And I didn't really understand that my neck pain is derived from my right leg problem.
Mm. And it's interesting. This is a big issue I see, and perhaps you see the same issue occurring where we live in a world where we're becoming more specialized, and you see it certainly within physiotherapy, physical therapy, where you become a specialist where you treat shoulder problems, neck problems, hip problems. And that's not to suggest that some of the people who are specialists don't have amazing knowledge. I've met some of these people and they have such an intricate understanding and detail of the anatomy, the very common types of pathologies that can occur, in addition to certain modalities that may help restore or improve function within that segment. But I often think about this as the idea of the proximate versus the ultimate causes, because obviously, if someone comes in with neck pain, using this as an example, I mean, you're perhaps an exception where treating the neck actually made you feel
Yeah.
worse. But there's obviously a lot of things that you can do where you go, oh, yes, like my neck does feel better. But that subsequent repeating pattern of something coming back makes you think of, am I only treating the symptoms here, so to speak? Is there something else here that I haven't taken into consideration? And it really helps you to appreciate and understand about someone's past medical history, about how those things may be contributing to it. Because I sometimes think about that. We often think about that from a macro biomechanical standpoint to go, oh, yes, that old ankle injury, you've got reduced dorsiflexion, your plantar flexion strength is down. And not to say that those things are not relevant and very important for resolving some type of biomechanical issue up somewhere in the kinetic chain. But that ability to also be able to feel changes within the tissue, and obviously the fascial system is something that's very evident to see, where you get these so-called
Hmm.
dysfunctions, these densifications, which aren't necessarily some type of structural
Yeah.
pathology. You're not necessarily going to see it on some type of radiological scan, yet actually is something that is well, perhaps in the future we will be able to quantify it through certain types
Yeah,
of
but you can see it in
radio.
ultrasound and MRI.
This is true.
So it's
Yes.
quite easier today to actually see it, and we use ultrasound in the clinic. We can see where you have
Mm,
more loose
mm.
connective tissue, and you can see where you have actually the densification. So,
Well, interestingly, do you use a lot of ultrasound to be able to observe that?
well, actually, yeah, sometimes, yeah. I have now a
Mm,
patient with a very, she had a cancer in her jaw, and she got a
mm,
reconstruction of all the jaw from her fibula.
hmm,
But she did 9 surgeries without really any physical therapy in between. So now she can open the mouth only for 1 centimeter. And actually, I did an ultrasound in all the area of the masseter and all the area of the muscle
mm.
because I wanted to see, is it all fibrosis? So would I see only
Yes.
like white, a lot of collagen fibers, or do I see also densification? What is the organization of this? And actually, it helps a
Mm,
lot just to understand what I have there. So this is, for example, a
mm.
case I do use ultrasound in the clinic, and actually it helps.
I'd be interested to talk more about how you apply fascial manipulation to your
Yeah,
gymnasts,
let's go
because
back.
I think you're probably. Yeah, yeah. Well, I mean, we could also maybe use you as a case study, but um, thinking of the fact that you are working with elite athletes, and I know this is something that you use not necessarily just to actually say treat pain,
Yeah.
but also to really improve the mechanics. And I know this is, I know, well, I'll let you tell the story or give an example of some of the athletes you see and how you're actually implementing it.
Yeah, so I think that one of the main thing in sports field with when you deal with elite sportsmen is not only to repair and to rehabilitate them as fast as you can, but actually to prevent injuries. Now, everybody is talking about prevention of injuries in elite sportsmen, but actually we don't have very good ways to do it. Let's
Mm,
speak the truth. And one more thing that is very difficult is actually the maintenance. the maintenance of their abilities and allowing them to actually be better and better, because every day they train, they try to be better than the day before. So they actually ask their body to be much more faster, with more strength, with more accurate. And this is something you have to provide them as physical therapists. This is how I see when I maintain a body of a sportsman. I have to, first of all, allow him to be better and support him. Second, to maintain those abilities. And three, of course, if they have injury, and they always work in their top abilities. And they will have injuries because you cannot work 100% every day and not to get injured. So I
Mm,
have to rehabilitate them as fast as I can. So when I use fascial manipulation, actually this is, look, as a sports physical therapy, I seek for the most accurate, fast treating treatments. Okay, because we don't have time to waste. We don't have time to do
mm,
8 treatments of something that I can fix in 1 treatment. We really don't have time. So this is why we really search for the methods where you can have the fastest results and the best results. And actually, this is why I really like fascial manipulation for sportsmen, because they give you a
mm.
very, very fast result. So a sportsman can come to you with some kind, he tells me, listen, I don't have enough of strength. I feel that I cannot really, for example, like do this with a lot of strength. I feel something like weakness in my hand. And then you do the treatment and they say, okay, now I feel better. Now I can take the ball and I can throw him much better
But
with more strength.
yes.
So it doesn't like it's not like you had a hypertrophy in half an hour that you did the treatment, but actually you allowed this organization of the muscle fibers, the recruitment, the correct recruitment of the muscle fibers, to allow with all, it's complex, it's not only muscle fibers, we know that, but we allow
Mm.
all this organism to actually be with more strength, more accurate, with better coordination.
Yeah, and what I think that highlights too here is a big issue I see, and this is perhaps maybe more of an issue in Australia within physiotherapy, is when we see a dysfunction, people are always looking to apply exercises.
Mm-hmm.
Okay, we need to do this exercise to improve your flexibility, to increase your strength, to, quote unquote, change motor control. But I find that the limitation with that is you're looking at motor output, not the concept of sensory motor output. Because sometimes the issue is not about having to, say, educate or learn a new particular movement. The issue may be actually coming from a change within the peripheral tissue, as you're alluding to here. And this is where I think it's really important to highlight when we talk about, I think, particularly fascia, is it is so highly innervated. It's such an important sensory organ that helps to provide a lot of feedback to our spinal cord and brain that influences the output of muscles. And actually, someone I know in Australia who's done fascial manipulation, she put it very eloquently, and I thought there's a good way to describe it. Is she said that muscle is fascia speech.
Mm.
And so the way I think about that is we have this sensory organ that's continuously providing feedback to us that then helps to coordinate the complexity of what muscles, and more specifically what motor units within the muscle, are contracting to be able to create an effective fluid movement. And so I think sometimes the limitation we see from, whether it's about a high performance and trying to maintain that, and, maybe seeing a lack of the ability to maintain that performance, or let alone the injury. And I mean, we've given some examples it's already of you with your old ankle injury, the individual with Bell's palsy with the wrist fracture, of how sometimes the limitation is not about, well, what exercise do I need to do? It's more about, is the issue more of a sensory input or an altered sensory input not the lack of that's causing the altered motor output, whether it's from a force production or a coordination perspective.
Let's take an example, okay? What about
Mm.
Achilles tendinopathy? We treat it a lot, right?
Sure.
Gymnasts have it a lot, because they are constantly going on their tiptoes. So, usually, what do you give to Achilles tendinopathy as a physical therapist?
Well, we tendinopathy research is very big here in Australia, and the standards typically are around resistance training,
Mm-hmm.
and typically doing things like often there's a lot of discussion about isometric contractions
Yes,
for pain modulation, and then certainly doing some heavy maximal voluntary contractions are pretty typical standard protocols.
very good. But if you are a physical therapist that work with gymnasts and you will give them some kind of resistance training, right? What does she do 12 hours a day? She's,
Well, I'm tipping on.
yeah,
No, go.
go, tell me. So,
Well, she's obviously doing a lot of repetitive calf contractions already.
exactly. So, we got one physical therapist now because I wanted to have another physical therapist and we wanted to check her. And we gave her a girl with Achilles tendinopathy. And the first thing she said, well, go and do 50 times a day, do like releve. So go on your tiptoes and strengthening. But I told her,
Yes.
listen, she's doing it thousands of times a day, not
Mm,
50 times, because
mm,
this is what she's doing 12 hours a day. But when you're thinking in a different kind of way, because actually this gymnast, due to overuse, has densifications and part of her muscle fibers and motor units, actually, let's speak about motor units, cannot recruit. So all her vector of work and pulling the tendon is not correct, what actually creates Achilles tendinopathy. So let me tell you that with
mm.
one or two treatments in the places of densification, by the way, it's not only on the calf, because she's working in a chain, I have to work in a chain, okay, together with the
Mm.
antagonist and the agonist muscles, it disappears.
And it's interesting because I think about my own experiences of, say, applying, say, conventional, doing heavy resistance training, for an example. You don't necessarily always see the result you get, you want, sorry, I should say. And so that straight away starts to think of, well, how do I need to, what other potential things can I consider?
Mm-hmm.
And the other thing I think about too is, as you mentioned about, is there alterations in the force vectors that alter the forces through the tendon or the subtendons? But then, of course, we can also consider how the crural fascia of the lower leg does provide the epitendon of the Achilles tendon itself,
Yeah.
and that we certainly see in individuals who have Achilles tendinopathy. You can see changes in the thickness of the crural fascia that's often reflective of a densification that can
Mm-hmm.
create some compression of the Achilles tendon itself as well. And that certainly has implications for the types of forces that the Achilles tendon is experiencing, because it's potentially creating more compression due to the tension of the surrounding crural fascia. And again, really highlights that. Well, actually, this is maybe another question to ask you too. When it comes to treating densifications in the fascial system, they appear to be very localized, and they appear to happen in very specific patterns or areas of the body. And it doesn't seem that exercise is something that's very good at getting rid of
No,
densifications.
we know
And so,
today we know that,
no, go.
yeah, today we know that densifications are also created by the change of pH, right?
Mm,
And well, this is a huge topic, and I think that this is
it
a
is.
but all the DOMs after exercise, right?
Yes.
What is it? Now
Mm,
they think a lot that maybe it is a change of loose connective tissue. So What I can tell you, and this is something that I can see also clinically, but I think that the research will catch us in the next
Mm,
4 or 5 years, maybe even 3 years, that overuse load or very high load like elite athletes, or even not elite athletes, but few hours a day, can create densifications by itself. And not only
mm,
injury or fracture or immobilization or something like a surgery, like we thought.
mm. Well, so interesting. I don't know if you know the work of I think his name's Jan Wilke. He's a researcher from Germany. He's done a lot of research in fascia, and he's published quite a couple of articles now talking about specifically DOMS. And in short, there's a lot of research showing that when you induce DOMS, you see a changing in the thickness of the fascia. And interestingly, when you look at the correlation of how the thickness changes over 24, 48 hours, it correlates much better with the peak pain experience from DOMS, as opposed to things like some of the other hypotheses around, for instance, what's the word? What's the creatine kinase? You know,
Mm-hmm.
it's an enzyme of muscle
Yeah.
damage. Or like perhaps too much calcium secretion, but that doesn't appear to be an issue within DOMS itself. And so it's interesting though too. I often think about, is the response of developing a densification from overload also reflective of the fact that hyaluronan,
Mm-hmm.
seems to be which is obviously a very important molecule in the fascial system that typically will act like a lubricant,
Mm-hmm.
can also be anti-inflammatory if it's a large size hyaluronan. So I do wonder if the response of the body is hyaluronan being secreted excessively to be able to neutralize the inflammatory or pH state,
Mm-hmm.
but then leads to a potential densification because too much hyaluronan, obviously within loose connective tissue, binds to each other, which is what forms a densification. And I realize for listeners, this is a very a very crude biochemistry lesson, but I have talked a lot about this in previous podcasts, so I'd recommend people listening to some of the other ones to hear a bit more about this. But it's something that I think we see a lot within
Yeah.
athletes. But
Let's simplify.
the other,
You
yes,
know that
please
I like
do.
to simplify, especially for people that are not fascial manipulators. So what we can see that sometimes a lot of exercises, recurrent exercise with a lot of load, can create themselves densifications. So where is, and this is something, but you have to use strengthening, you have to use exercises to with sportsmen, with regular people, to rehabilitate them.
Mm.
Well, this is a good question. I think that, again, we're not going to go too deep to the subject.
It is. But this is also, I think, a really important point to highlight because I feel like a lot of manual therapy is being pushed aside as saying, well, manual therapy doesn't do anything. We should just be focusing on exercise. But this is where a very clear distinction I often make is one of the benefits of manual therapy is we can localize to a very small area, a very small surface area where the mechanical forces are
Mm-hmm.
applied. And that's obviously one of the limitations, but also potentially benefits of exercise because it's much broad in
Yes.
how forces are distributed and dissipated. And this is something that I think is a important comment to make because it helps you to appreciate that when we want to change tissue mechanics or tissue quality, it's our hands that are able to very much localize where the forces are applied to treat something like a densification. And perhaps one of the reasons why we don't necessarily see at this point any indications that exercise can reverse a densification. Though maybe certain types of exercise might mitigate the formations of densification, but
Yes.
that's perhaps a conversation for another day. Um, Now, one of the interesting things that you do as a working with gymnasts, I think, is gymnasts have very specific requirements because they obviously have to have such high levels of flexibility,
Mm-hmm.
yet they have to express strength through that large range as well.
Yeah.
And this is an interesting conversation because when we talk about something like stretching,
Hmm.
I feel like stretching is something that's very much out of vogue. I feel like a lot of people say that you shouldn't stretch for this reason, that reason. Um, how do you apply the development of certain tissue capacities like flexibility and strength to your athletes? And do you see that those things work synergistically, or do you see them as often competing with each other in terms of maintaining them with gymnasts?
Yeah, well, actually, it's a very good question. And I think that gymnasts are a very good population to test that because they are so, so flexible. But also
Hmm.
inside gymnasts, we have the super, super flexible girls that maybe are EDS, maybe they have some kind of EDS and we don't know and they don't know for sure.
Mm,
But there are also gymnasts that are very flexible, but if we compare them to regular population, but not as
mm,
other gymnasts. And then, yes, I can see that in a gymnast that they are more like EDS, they
mm,
have a lot of problem with strength, with developing strength. And they are very problematic in stabilization of their bodies during certain exercises and during specific things that they're doing. Whether the regular gymnasts, which are flexible but not too much, they have more possibility to actually be strong and but also very flexible. But I
mm,
can tell you that today, even a gymnast, because they're being stretched so much, also by their coaches, also by themselves, every day that they're starting their training, they are stretching at least half an hour, which is a lot.
mm,
So I can tell you that
mm,
we had a lot of injuries, a lot of muscle strain injuries because of those stretching. Also passive stretching, which is very problematic because you don't feel the border and the limit of the gymnast. You just
mm,
stretch. But I can tell you that since I think 5 years, that all the gymnasts that are working with me, by the way, most of the gymnasts in Israel, because they copy each other, they started to use foam rolling before the stretching. So I can tell you that if you use foam rolling, so you actually work a little bit on the connective tissue before the passive stretching. First of all, the stretching is much easier. Second, I can tell you for sure, we reduce maybe in 90% or even more the amount of injuries of some kind of muscle strains due to passive stretching, which is amazing. By the way, we don't see it on research yet. Maybe we have
mm.
to research that you should use foam rolling before stretching and on the benefits of it. But you cannot see it in research yet. But I can tell you that clinically, we've reduced a big time the amount of injuries.
Out of interest here, so you talked about stretching and particularly like doing, say, passive static stretching. Was there seems to be a correlation with gymnasts potentially injuring themselves? Do you think that's a more unique trait to gymnasts? Because I think of, say, stretching myself. I do a lot of stretching in yoga, and my flexibility is okay, but it's certainly no gymnast standard. And I feel like for me that I get enough feedback in terms of pain or discomfort when I stretch to go, okay, I'm limited to how far I can go in. Is the issue that you see in gymnasts is their flexibility is so good that they actually just don't necessarily get that sensory feedback? Is that something that you think's going on where they then get that or like stretch type
No,
injury in their
they actually
muscles?
they have a very good sensory, they sense. It's just that
Yeah,
sometimes
okay.
the passive stretching is when your coach is stretching you and the coach is
Mm,
going over your limit. So trust me, they feel
yes,
it.
okay.
They feel it.
Okay.
And
Okay.
by the way,
Yeah.
connect also to the new research about when you have a limitation, when you feel a limitation in your stretch, what limits you? Is it the muscle or is it the fascia?
Yes. And certainly the connection of fascia to the brain, because it seems that so much of the adaptations to stretch is often like a centrally mediated thing to begin with too.
Yeah, yeah. So
Now, what do you think's going on then with foam rolling? Why do you think foam rolling seems to be something that then enhances someone's ability to stretch further and potentially mitigate injuries, particularly in gymnasts here?
well, if we look on the latest research, so maybe what is actually limiting us is more the connective tissue rather than the muscle itself.
Mm.
And when we are doing a correct foam rolling and not just sitting on it, okay, because you have also different types of how do you do foam rolling, how do you roll in it. So if you roll in the correct way, by the way, I always teach my patients agonist and antagonist, right?
Mm.
So when you foam roll on the correct way, you actually maybe affect a little bit the connective tissue, which allows you to get more of your flexibility immediately. And
Mm.
this is, by the way, try it yourself. It helps me a lot, and I can really see how it works on my patients and gymnasts. So we use it a lot now.
Do you ever use vibration? Because I know that's something that's been used before to vibrate tissue and seeing big improvements in flexibility.
Yeah, for me it didn't work. I tried. We had
No, okay.
the guns. Yeah.
Yes.
Also in the Israeli rhythmic gymnastics team, but it didn't help. The foam rolling is the best.
Mm. But so your athletes are still doing a lot of stretching though. Like
Yeah,
that is a core part of what they're doing.
yeah,
There's been a lot of research, and perhaps you've come across this, and I've actually spoken to some researchers in stretching about this, where there's been a lot of studies where they grab a random group of people who've never done stretching, they get them to stretch for hold a stretch for 5, 10, 15 minutes, and then they look at force output of the muscle. And they often see a big
yeah.
decrement in their force
But
output.
also only if
Now,
you're doing a static stretch. If you're doing a dynamic stretch, it's actually not reducing your force.
sure. And the other big one to also understand too is there's limitations in the methodology
Yeah,
because these people have never done stretching before as well, which to me is it seems like a big issue because the way I look at that is imagine if you went to the gym for the first time ever and did a session and then measured force output, you'd expect your force output to be down quite dramatically because your body's not used to that type of stimulus. And I'm interested for your gymnasts who have obviously done a lot of
hmm.
stretching, do you see that relationship where their force output goes down, or do you think that doesn't occur once you've actually got a good stretch tolerance and stretch
So
history?
actually, I can tell you that in Israel, we changed the way we stretch. I changed all the way
Mm.
that they're stretching. Because when I was a gymnast, we were sitting in shpagat, right, in splits,
Yes.
for 5 minutes, 10 minutes, 15 minutes, then other
Mm.
splits, and that's all. And then you were ready. But
Yes.
now
Okay.
the gymnasts in the Israeli team, I can tell you that they're doing dynamic stretching. So they
Mm.
have coordination with music, by the way. So their stretching is dynamic. It actually with all the body together with the neck, with all the segments, not only the legs, for example, or the back. So they're
Mm.
doing it
Mm.
correctly. And before that, they're doing foam rolling, and then they're doing
Mm.
dynamic stretching with music, which is like with choreography and so on. And then
Yes.
I don't see a really a fall of strength. But we change
Yes.
all how we stretch just because of the research.
Yeah, and I guess that's also then highlights doing more sport specific types of activities. Now, when you're talking about this, I'm assuming this is a part of their warm up,
Yeah,
yes, before they go into their main training
yeah.
session. Are there periods where they're doing, say, other stretching, including static stretching, say after a training session? Is there any? Do you see a role for static stretching in gymnasts as well, but not perhaps in a warm up?
Yeah, I give them. Usually they're very, very limited in their dorsiflexion, just
Yes.
because
Okay.
they're all day long in plantar flexion. So
Yes.
though,
Yes.
and then they are when you have a limitation in dorsiflexion in the leg, so what they do, they're actually
Mm,
collapsing medially. And when we have all
yes.
the problems of collapsing, pes planus, right? So the collapse. So what we're doing, those girls, they have, first of all, also in the end of their all the exercises, they have specific stretching, right, for improving dorsiflexion. And
Hmm.
then they have also active exercise to allow and to build all the arch again. So
Yes.
they do have.
Yeah. So it's that concept of trying to maintain, say, active stiffness in one area whilst lengthening elsewhere within the kinetic
Yeah.
chain. Yeah. So you don't, I always, there's a very useful saying that is the body always follows the pathway of least resistance.
Mhm.
And obviously, when you're creating complex movement and you're moving through multiple joints, you're often going to lengthen through one area where it's a lot easier at the expense of others because it's stiffer or restricted. Do do your athletes do resistance training? Are they actually in the gym as well to do strengthening work?
They do a lot of strengthening work, a lot. And first of all, they have it during the warm up. So about half an
Yes.
hour from the warm up is a specific resisting training. And then in the end of the session, in the end of their day, each gymnast has her own specific exercise that she needs to
Mm.
do. That, of course, I give her according to her situation, her problems, her pains, the areas of the body she needs to strengthen. And they have something like half an hour to 1 hour that they're doing it also. So yeah, they're doing a
Mm.
lot of resistance and exercises.
You know, it's interesting when you look at athletes who transfer from one sport to another. A common one that you see is you see gymnasts going into weightlifting,
I didn't
and
see
it's an
that.
interesting.
Did you see that?
Ah, yeah, no, I've seen it quite a few people I know, and these may be some athletes who become elite athletes,
Really?
but certainly,
But from
yeah,
artistic
and it's interesting.
gymnastic, not from rhythmic gymnastics.
That may
Yeah.
be the case, yes, and maybe the caveat. To be honest, I'm not too too well versed on the different forms of in gymnastics, but the reason why I bring it up is I think about something that you see in gymnasts is one, they obviously have such an amazing flexibility, and therefore their ability to move through range and do something like a deep squat is so effortless. Where
Actually,
for
no,
most of
they
us,
cannot do deep squats, by the way.
because of the
Yes,
dorsiflexion,
they're limited. They can get
interesting,
to
yeah.
90 degrees. And if you don't want them to raise their heels, they can get to 90 degrees. That's all.
Right. Okay. Well, perhaps some of the individuals I've seen have been at the gymnasts who haven't gone all the way to the top because some of these people have still got quite amazing dorsiflexion where they can do a deep squat very easily. But the other thing that's very clear to see is they can express force through that whole range.
Hmm.
And I think that's something that for a lot of us mortals, including myself, we're trying to push myself into a deep squat because the freedom of movement isn't necessarily there. And it's actually, there's this internal resistance of trying to get into deeper positions. And I know and work with quite a few weightlifters who may actually be able to express are quite strong, but they're strong within a very limited range.
Hmm.
And so when you think about weightlifting and the importance of getting into a deep squat or a snatch position, the ability to have really good strength in that end range position at the shoulder, at the ankle, at the knee, at the hip is limited because of that internal resistance that's fighting. And so I always find it interesting to see the training of a gymnast to understand how they find that relationship between flexibility and strength. And the reality is it sounds like a lot of time and effort needs to go into it too, because I know that a lot of your athletes are training multiple hours a
Yeah, at
day.
least 10 hours a day. At least.
Mm.
At least.
Now, something else that's and you've done, Natalie, is you've been to several Olympics now. So you've done
Yeah.
three Olympic cycles: 2016, 2020, and 2024.
Yeah.
And it's always interesting to talk to people like yourself as a physical therapist who's gone all the way to the top. And I imagine that influences a lot what you do with your athletes now, because you're probably used to that 4-year cycle,
Hmm.
thinking about how you develop and progress to the next Olympics. So I'm interested to hear your experiences with that. Now that you've done a few cycles, how has that actually developed and changed your professional approach with what you do with these athletes?
Well, let's say first that I have two Olympic medals from two cycles.
This is true.
Uh,
And congratulations too on your most recent performance of one of your athletes.
Thank you,
Yes?
thank you. So we have a gold medal from Tokyo 2020, 2021, and a silver medal from Paris 2024. And we can't wait to Los Angeles 2028. And I can tell
Mm,
you that when now I work on cycles with my gymnast, we work in much more organized, I think, way. So I understood, first of all, the meaning of maintenance and the meaning of um, like how to prepare the gymnast body to the next 4 years. So in the
mm,
beginning of the cycle, this is by the way I did last week, I came to all the gymnasts and I started and I checked one by one. And by looking on the new constitution, I understood which injuries she can get. And
mm,
from the injuries they can get due to the new constitution, actually each girl got her own exercises to the next few months. This is first of all, and this is something very important when you understand the sport. You have to look on the effect of the sport specific on the gymnast, because if you don't understand the sport, then you cannot really treat well. I think you have to understand very well the sports. So first of all, I think that the first year is actually building their bodies and allowing their bodies to go through 10 hours of training every day, and
mm,
explaining them how to live with their bodies in peace. I mean, how much time you need to rest, what is the rest you need, which exercise you need to do, how do you need to treat your body every day. And of course, also along the maintenance, because if you only treat the sportsmen before the Olympics or during the last year, they're not gonna survive this cycle. You have
mm,
to treat their bodies, you have to maintain their bodies through all the 4 years, and actually building their bodies step by step to the goal, because the goal cannot be in a year, the goal is in 4 years.
mm. And so, and you very much look at it from that perspective that it's not about like, obviously there are important events and competitions for next year, for instance, but ultimately the process is that 4-year
Yeah.
cycle. You're not necessarily thinking 1 year
No.
and then reassess. You're thinking this is how we need to plan 2025, 2026, 2027 to prepare for 2028.
Yeah, even in the competition organization, we know that
Mm,
before the European Championships, you have a lot of pressure and a lot of stress on your bodies. So you know that you have specific amount of even treatments and trainings, and then you know how much time to give them after European Championships in order them to be in the peak in the World Championships. But again, it's not only the coach deciding about the trainings; it's also the physical therapist deciding about the treatments. And I think that this is the most important.
mm,
Their bodies is organized not only by trainings, but also by treatments. So we like go
yes.
together in all these 4 years. Maybe this is
Mm.
the biggest difference.
When you talk about treatment, what kind of treatment are we talking about? Are you talking about manual therapy? Are there other treatment modalities that you're using? What kind of things that you're applying to these athletes?
So first of all, of course, manual therapy. This is the basic. I think this is the best maintenance their body can have. But of course, I
Mm,
use many more things like dry needling and taping and mulligan and some kind of different mobilizations and neurodynamics. So, and of course, exercise, which we already spoke about. But the manual therapy is the basic. For me, it's like, how do you say, plastiline, right?
Hmm.
So they need to be flowers. We need to make flowers from their bodies. If the
Okay.
plastiline is not ready for that, you cannot really work with their bodies. So I prepare their bodies with manual therapy, of course, also with exercise that we do every day,
Mm.
and then they can create the flowers. If the body is not ready, you're gonna break it.
Mm. Yeah, yeah. I think of the analogy of you've got to prepare the soil so that the plants can reach their utmost potential, so to speak.
Exactly.
Now, you talked about obviously manual therapy being a big part, and you also talked about different types of manual
Hmm.
therapy. How do you start to thinking about how you apply different manual therapies? Because I think often manual therapy gets lumped in as sort of the same category, but the reality is the effect and even the stress, for instance, of some type of soft tissue work versus say a mulligans versus say dry needling versus say fascial
Hmm.
manipulation have different stresses on the body. And I often think about manual therapy can be very therapeutic, but it also can create a bit of a stress in itself. So do you think about structuring manual therapy to elicit different effects on the body? And do you sort of plan that out through the week based on their training sessions?
Yeah, so there are a few questions in your one question. So first of all,
There is.
when working with athletes and when they're used to get manual therapy on their bodies, each treatment is much easier. So
Yes,
it's
okay.
not like you got one time a year manual therapy, fascial manipulation, and then everything feels like it hurts for 48 hours. But
Mm,
immediately, usually I do sometimes the treatment and they immediately go to training because they feel that their body is working better in the training immediately after my treatment, and not if I'm doing it in
mm,
the evening. This is, for
yeah.
example, interesting. Um,
Yes, and I guess it's similar to the idea of say stretching, where their bodies are used to stretching, so stretching helps them prepare for their training session. Or I guess if they're doing 10 hours of training, they're not going from 0 to 10. There is a structure for them, probably when they first start gymnastics from very
yeah.
young, of actually building up to be able to tolerate that stress.
Yeah. So this is first. Second of all, then you have to think if you work with different modalities and different techniques, you have to think what are you doing and why. So for me, when I do fascial manipulation, this is the basis. This is the basis of allowing the tissue to correctly function. So first of all, I will do, for example, fascial manipulation, and then I will do Mulligan. Because if you have a different tension even on the joints, then you do the fascia manipulation, then you do the Mulligan, I see better results than doing in the beginning Mulligan and then fascia manipulation. This
Yes.
is one. Second, if you use, for example, dry needling, so usually, one of the theories is that maybe the change of loose connective tissue is also what creating the trigger points, right? Because through the loose connective tissue, you have a perfusion of oxygen, of nutrients to the cells. When
Mm,
you have a change of loose connective tissue, you change all of that, and then maybe again, maybe it's a lot of options. Maybe this is one of the
yes.
option to a trigger point to be created. So when in the clinic, if I do dry needling, for example, on one trigger point, sometimes we see it coming back after a week or after 2 weeks.
Mm,
So usually in the clinic, I
mm,
prefer
mm.
to release the densification. And then if I need and I have specific trigger point, I can really fix it with the needle, but not the opposite.
Yes.
Okay.
No, and I mean that's a whole nother interesting conversation in itself, because to talk about this concept of densification versus a
Yeah.
trigger point
Yes.
and how those things are related. But I have considered a similar hypothesis myself between looking at those relationships, because I've certainly seen that where treating trigger points alone may not necessarily resolve the trigger point.
Yeah, but then if you release the densification and you look 1 week after, 1 week, not 2 days, but 1 week after, sometimes the trigger point disappears, right?
Yes,
So it
yes.
depends if your sportsman have this week, or if he has a game in 2 days and he needs to function in 2 days, and then you will use densification
Mm.
and you will use the dry needling.
Yeah, yeah. And it's actually, I mean, I guess for your athletes, they can tolerate all these different types of manual therapies. But I'm often thinking with some of the athletes I work with who may not necessarily get as much manual therapy input.
Yeah,
It's an interesting consideration to think about if they're performing tomorrow in 2 days' time, what is the most appropriate modality? Because for those of you who aren't familiar with, often treating densifications is a more intense, very localized type of treatment that can cause a bit more of an inflammatory response acutely, which is a part of the process of restoring the tissue mechanics. But it obviously, as a result, can cause some soreness to the following days. But obviously, the more you get it, the more accustomed your body gets to it.
yeah. And then again, if you treat different places or different densifications and stay less time on each point, then also
Mm,
sometimes the pain that the patient feel later is less. So you
yes.
can you can really use different techniques, different thinking, to really create the perfect suit for your patient.
Mm. Just actually on that point, jumping back, we talked briefly before about the application of fascial manipulation to improve biomechanics, not necessarily to treat pain.
Hmm.
How do you go about assessing a gymnast? I'm assuming for you, you get a gymnast coming in. The coach says this person is struggling to do a particular
Yeah,
movement behind their
yeah.
back. How do you go through that process of then assessing that individual to think about where you think the problem is originating, and if whether there is a connective tissue densification that's contributing to it?
Wow, this is, I think about all the thinking process that you make. And
Yes,
okay, where do I start? How do I explain it? Um, well,
because does a lot of it come to you to actually to observe that individual trying to
yeah,
do the particular
yeah,
move and going, here is where you see the.
I look at
Mhm.
her and I see what are the compensations that she's using.
Mm.
Whether she's compensating because she doesn't have enough of range of motion, or she does have enough of range of motion, but inside that range of motion, she tells me that her movement is not coordinated.
Yes, okay.
So you start to think from that. And then by knowing also the gymnast, you understand if she's not very flexible, for example, if she's very close here. So you understand that maybe even you have to something, the tension is derived even from her hip and not from the hand itself. So it's a lot
Yes.
of collaborating the mechanics, the understanding of the fascial continuity, the sports, seeing her do that, and the compensations she's doing, and also knowing what fascia can do. Because when you know that you can change the coordination of movement because of the different muscle fibers and the different motor units that are working to allow one movement to create, then you start to think differently. Um,
And I think, well, I was going to say, I think it's also that's where it's very helpful to be an ex gymnast yourself, because you have an appreciation for understanding what are the movement qualities that this individual is trying to achieve, and what are the things that they need to be able to do so effortlessly and effectively to score high.
yeah,
Now, I'm cognizant of
yeah.
time, and one of the questions I always like to ask our guest Natalie is something that you're interested in learning at the moment.
Mhm.
And it can be related to your professional work, but it's also interesting to hear about things that you're doing outside of your professional work as well, potentially.
Yeah, well, I have three things now. So first of all, I'm learning first of all, much more about the ultrasound. This is first of all, but
Oh,
this is
yes.
like
Okay.
kind of regular for a physical therapist, I think.
Mm.
The second,
Well, to be fair, we never really learned much about ultrasound assessment, and from what I understand, it's actually a lot more complex than it may seem because it's very subjective
yes,
about how you assess it as
yeah,
well.
yeah, yeah, it's subjective. You have to understand the anatomy of what you see exactly. This is for sure. And yeah, it's quite subjective, but it is very interesting working in the clinic. So this is first.
Mm,
Second, I
mm,
work a lot with women after breast cancer. This is in the physical therapy world.
okay.
So,
Yes.
and this is again a huge subject that I'm dealing with. Um, Third, not in the physical therapy world, is actually the mechanotransduction, which I am very, very interested
Mm,
in. And I read a
yes.
lot about it, and I'm starting to really go deep in it. It's super interesting together with the epigenetics, with the expression,
Mm.
and so on. So those are my topics now. And
Well, just interestingly, you talk about mechanotransduction and epigenetics. What are you looking at specifically?
so I started with Bruce Lipton from
Oh,
epigenetics, and you
yes,
know the basic book, the
the
biology
biology
of
of
belief.
belief.
Yeah. So
I've read it myself.
yes, this
Yes.
was my first gate to the subject.
Mm,
Um,
mm,
and then all the expression of genes, I really looking forward how the loose connective tissue is actually affecting the epigenetics,
mm,
and taking that with the new research about cancer.
mm,
This is super, super interesting. So now I'm going deep
mm,
together with the research of the mechanics also of loose connective tissue, together with the research in
mm,
cancer, together with the mechanotransduction. So this is, and
mm.
together it's a lot of information from different subjects, but it comes together and it's super interesting.
At the end of this podcast, I'll share some articles with you from a medical doctor over in the States who's has a clinic treating people with hypermobility. And he's done a bit of research looking at certain genetic polymorphisms associated with hypermobility and
Mm-hmm.
EDS. And so he's found that certain genetic polymorphisms are more common in individuals with EDS that he believes contribute to dysfunctional formation of connective tissue that contributes to the symptoms of EDS, both within the musculoskeletal system, but obviously internally too, because the connective tissue that's affected is not just the muscular tissue.
Yeah.
So I'll send you that because there's there's some interesting protocols of things that he looks at to one testing certain genes, but two testing certain nutritional status of the individual that seem to be correlated with these genetic polymorphisms that contribute to the signs and symptoms of EDS. So I also find this stuff very fascinating too, and I think particularly with the relationship between nutrition and genetics, so nutrigenomics, because it seems that we all have certain genetic polymorphisms that mean that I need to consume more of these vitamins or minerals to actually maintain a better
Yeah.
physiology, and that seems to vary from person to person.
Yeah. So we have so much to
Well,
speak about.
Well, it's just the start. Natalie, thank you very much for taking up some of your time today to come and talk to me. I'm really excited to get this podcast out. I think it's a really great discussion, and it's great to talk to you.
Thank you, Jack. Thank you and everything that you're doing. And I will be happy to speak with
No,
you more. Thanks.
yeah, thank you. And again, for our listeners, please do like, subscribe, leave a comment. It does help us to be able to spread this our work and reach more people.